Good morning. Thanks for having me. So my talk is about the IEM and by the Chicago classification 4. What is it? And will flip panometry help? I really have no disclosures. I do love this esophageal motility, and I was telling Lena that if I were going to stop operating, I can do this all day long. But I have no other disclosures. All right, so what is IEM? Well, there's an ICD code for it. It still uses an old term, dyskinesia of the esophagus. It's a problem of the distal esophagus. It's typically measured between 3 and 8 centimeters above the lower esophageal sphincter. It doesn't do anything for the upper portion of the esophagus. It's actually very common, and Don Castell keeps reminding us that it's probably 30, sometimes he says more, of esophageal physiology tests will show some type of IEM, but it was formerly called nonspecific esophageal motility disorder. And I don't know, maybe about 15, 20 years ago, they kind of started moving away from that terminology. I keep that terminology in mind only because it used to be a bucket of like where you put things you can't have a label for, they just put it into that category. Well, the understanding of IEM is evolving. It's moved from line tracings to high-resolution manometry, where now you have 3D architecture of your peristalsis. But historically, it's more than 3 out of 10, or 30% weak contractions, which means amplitude of less than 30 millimeters of mercury, or more than 30% dropped, incomplete, or failed peristalsis. And I keep that in mind as really our anchoring point as different definitions evolve. For the surgeon, the bottom line is, are you going to do a fundoplication or not? And if you do, what kind are you going to do? So what does IEM feel like for the patient? Well, there are 2 symptom categories. Dysphagia is probably the most common, and some form of heartburn-related symptoms. The converging point is that it has disrupted bolus transit, and we should remember that, okay? Don Castell pulled his 200-something patients together to talk about the symptoms of IEM, and most of the commonest one is really dysphagia. Interesting is that 50% of IEM have GERD associated with it, and the more severe the GERD it is, such as esophagitis, Barrett's esophagus, you will have more findings of IEM. Other associations are diabetes, reactive airway disease, people with pulmonary issues, or connective tissue disease, neuropathy, malignancy, eosinophilic esophagitis. They have been associated with it. And I will also add to this list surgery that has been performed in the neck area and in your lungs sometimes can be associated with this. Well, this is what it looks like on high-resolution manometry. This is the distance, and this is time. And this is as you swallow something, the bolus will keep moving down in this like descending staircase pattern. Well, you can have a large break somewhere. This thing is more than 5 centimeters from here to here. You can have a complete failed peristalsis where you don't even see any of the bolus movement, or you can have distal small breaks. So by the IEM, is by the Chicago classification 3.0. I know we were talking about 4.0. 3.0, which came out 2015, the definition was greater than 50% swallows with low distal contraction DCI, integral, which is defined as less than 450. And normal is usually about 500 to 5,000. So that's a weak one, or you have more than half of them demonstrating weak peristalsis. If you have that, that was your definition. And it's really a mixture of failed swallows in the distal esophagus. There are some problems with using this Chicago classification. This is just a little bit editorial from my end as well. First, the pointer's not working, but that's okay. First is pre-2009, and that's the era that I grew up with. That's why most of us, the era that we grew up with, this Chicago classification 1, 2, 3, and 4, which came out January 2021. Before 2009, the definition was more than 30% weak contraction and more than 30% failed peristalsis. And then the Chicago classification came out, the IEM was just wiped off the map. Your identity was erased, right? And it wasn't there for 3 years later for Chicago classification 2. In 2015, the IEM came back out, and the definition at that time is what we described: more than 50% of weak peristalsis or or if you have failed, and if you have a DCI of less than 100, that's considered a failed peristalsis. Then 6 years later, which is last year, they came out with a more stringent definition of IEM, which is now more than 70% ineffective peristalsis, or more than 50% failed peristalsis. For the surgeon, in 2009, I would, if I had a patient with IEM, I would have said, you're getting partial fundoplication, or no fundoplication, or no surgery at all. It created a lot of confusion in 2009 when that was erased. I mean, and later on, 3 years later, it was no better. I answered a lot of phone calls, especially for transplant surgeons, lung transplant surgeons, saying, I got this data that says hypodysmotility or hypocontraction. What should I do with this information, right? And that created a lot of problems. In 2015, it came back on the scene with a definition as we had described. And now we have a more stringent definition, and this is why, as SAGES, we're talking about this. What do we do? Especially for those people who are between 50 and 70%, 75% ineffective swallows. What do you do with these patients? My other problem with the Chicago classification is that these studies were done in the supine position. And up until now, and I thought I was going to lose this battle, but now they're saying you will do 10 supine swallows, and you'll sit the patient up for 5 additional swallows later. And I think we're going to get more data coming out of that with the Chicago classification 5. So to summarize, IEM by Chicago classification 4 is more stringent than before. It's more than 70% ineffective peristalsis. Definition of that is a weak DCI of 450. It went up from 50% in the previous classification. And you can have more than 50% failed peristalsis, and that's also considered IEM. It does include the mixture of dropped or disrupted peristalsis, then they term that fragmented peristalsis. The indeterminate ones are still a big problem for us. And the question is, would you do a fundoplication on these patients, right? My recommendation is this. Is this dysphagia or reflux? You need to tease that out. pH studies will help you with that. You have to fix the hiatal hernia. There's more and more data that shows that fixing the hiatal hernia properly actually eliminates a lot of the reflux, and sometimes you don't need to do a fundoplication. If you're pushed, I would do some type of partial fundoplication. Now, panometry, will that help? This is the panometry. It's probably, I think the ticket price is about $85,000. It does have a tube that's a balloon, of the flimsiest water balloon you can imagine. It's passed down the esophagus. You can pull back. It comes in an 8 centimeter or a 16 centimeter long balloon, and it measures diameter and the compliance of that lower esophageal sphincter and how well it stretches. It's passed transorally. It's too difficult to put through the nose, so the patients need sedation, and it's usually done on the endoscopy table. And you just pump 10 cc's every minute, and then you do measurements that way. This is what a traditional line tracing looks like, and a manometry, high-resolution manometry, but this is what the panometry looks like. The red just shows narrower diameter. The lighter colors just shows that now you're putting more pressure into this balloon, and it gives you a wider diameter. So this is the normal output, and if you had to take anything home, these are the numbers you just commit to memory. The Distensibility index should be somewhere between 3 to 9 millimeters per square. It's a cross-section area divided by the pressure, and the diameter of the lower esophageal sphincter. The normal range is 12 to 18. For our IEM patients, I probably would recommend something a little bigger, like greater than 14 millimeters. Will it show peristalsis? Maybe, maybe not, right? Depends on how much you pump into the balloon. Most of the data is for lower esophageal sphincter compliance. It is not about peristalsis. And it's probably not helpful if you pump up the balloon to a full 70 cc's, because you're not going to see too much movement that way. So this is my reason for why flip panometry is not going to help with IEM. The top row is high-resolution manometry. You can see the descending staircase pattern for your swallows, the bolus movement. And with the flip manometry, all you're seeing is one whole column of the diameter, right? And remember, what is the common theme of IEM? It is disrupted bolus transit. And when you have a balloon occluding your esophagus, you're really not going to see the bolus move. And so for that reason, I don't think FLIP is very helpful for IEM. It's probably going to be helpful for other things that we're going to be talking about soon. So how can FLIP help IEM? Well, it's probably only intraoperatively. Right calibration for fundal plication, you want to determine the compliance, and you want to determine the diameter of the lower esophageal sphincter. So my final advice for surgeons will be this. Surgery cannot improve paracelsus. You only operate for debilitating reflux, aspiration, pulmonary issues, or to fix the hiatal hernia. You want to maximize the reflux management. Treat the eosinophilic esophagitis. Rule out connective tissue disorders. The data will show you that probably 66% of the patients will do better if you do these things well. About 1/3 will still not have any improvement. Study the tracings yourself. Visualize the bolus going down or coming back up. And you have to tease out whether this is reflux versus dysphagia. pH testing is important. Seeing the impedance studies is important. And functional evaluation, sometimes you can take some bread, dip it in barium, and watch this thing go down, or marshmallows if you prefer that. And wait, don't just rush to operate. Allow the disease to declare. And if you need to, you do a fundal plication or fix the hiatal hernia without a fundal plication. And I want to thank all those people who helped me put this information together.